Okay, welcome. I'm very pleased to welcome you to this e-cancer sessions concerning FGFR as an indicator of tumor-agnostic indication in different tumor type in this precision medicine approach. My name is Christophe Massard. I'm the head of the phase 1 department at Gustave Roussy. I'm a medical oncologist focused in GU cancer and glioblastoma.
Hello, everybody. My name is Eva Compérat. I'm uropathologist, so I'm more specialized on the bladder, of course. And we do, of course, we are implicated in this kind of FGFR-3 testing, especially in the bladder, where it seems to be pretty interesting. And I'm pleased to have a discussion with Christophe Massard.
So I guess the idea is probably to have an overview of the recent RAGNAR trial that was published and communicated during the last ASCO meeting. So this trial is an histology-agnostic trial. That means that the idea is to enroll patients with different tumor type, and we try to identify patients with FGFR alteration. The important things is we try also to identify FGFR positive tumor where FGFR seems to be oncogene addicted. So we use an algorithm to define different FGFR1, FGFR2, FGFR3 alterations. It could be mutation or alterations. And the idea of this trial comes from bladder cancer, because we know that in bladder cancer, FGFR fusion or mutation drive the cancer, and erdafitinib, an FGFR inhibitor, demonstrate significant activity in patients with metastatic bladder cancer. So the goal of the trial is to screen a large amount of patients. So we screen thousands and thousands of patients to identify the 5 or 10% of patients with FGFR positive tumors. It could be different tumor types. So for example, cholangiocarcinoma, glioblastoma, but also pancreatic cancer or breast cancer. And all these patients with these different tumors, if the tumor is FGFR positive with different and this very specific FGFR mutation or translocation, we propose to the patient to be enrolled in the clinical trial and treated by FGFR inhibitor erdafitinib. There are different FGFR inhibitors in the field. Erdafitinib seems very promising activity with a manageable toxicity and safety, and the trial is ongoing. We know that in some tumor type, like cholangiocarcinoma or glioma, patients with FGFR positive tumor seems to benefit or seems to have some benefit from FGFR and FGFR inhibitors. And in this trial, and it's very important also to have expertise of bladder cancer experts, because they know better than us manage the drug, and then also to how to implement FGFR screening in patients, because they already done this screening in bladder cancer in the past in the trial in bladder cancer. So I think it's the reason why it's also important to have Eva Compérat in this session, just maybe to give some information about the FGFR screening in bladder cancer.
Yeah, well, the problem is, of course, we know that FGFR3 is overexpressed in these luminal papillary tumors, which we know now from the molecular, well, let's say guidelines or consensus, which was published in 2020. The problem is, of course, that we do not recognize, for example, in the bladder, all the FGFR3 mutated by histology. I mean, we have quite a good idea if a tumor is extremely papillary, which of course happens, especially in the non-muscle invasive bladder cancers, where we know that FGFR3 mutations and alterations exist in nearly 50% of the tumors. Well, of course, we can suspect that then we can lead the patient towards, let's say, screening. Of course, we do not do screening for everybody. The most important thing is, of course, to do the screening in muscle invasive bladder cancers, but very often they're not really papillary, so we do not know very well whom to screen. So either you have the approach that you screen really everybody, which is not done. I think it is not really done, maybe in Gustave Roussy, because you're very rich over there, but otherwise it's not done in France and it's not done in Austria, where I'm actually working. So the problem is whom really we should choose, and this is, in my opinion, a little bit where the pathologist can guide you towards saying, well, this is a really papillary, even invasive tumor, but you should try. On the other hand, you have to be very careful also afterwards with the results, and I think Christophe, he knows much better than I do, but you have, of course, these hotspot mutations, which are really very well known, especially in the bladder. You have fusions also in the bladder, but you have these fusions much more in the gliomas, I think, which is pretty well known. So you really have to have a look at what you're looking at and what you're getting out, because you also have, for example, mutations like the V333M, which is a kind of mutation, but it is a resistance. So if you treat these patients with FGFR3, it will not work at all. So you really have to be very careful with what you take and what you treat.
I think it's very important because we know that it's quite difficult and challenging to address patients for molecular screening. So at this time, most of the patients are enrolled in molecular screening in clinical trial. I guess there are now a large program in France with a France genomic program, but also in different countries to have access more largely to this screening. But clearly, to have access to molecular screening is a challenge. And I think physician needs to address the challenge in their own hospital and discuss this option with patients. The second point is because FGFR is very challenging to analyze, we have different mutations, and sometimes the mutations are not oncogenic addicted, or you have mutation of resistance. So it's very important to have an interaction with a molecular biologist or pathologist to have this expertise on the oncogene addiction of the FGFR alterations. So that means probably in each hospital or each region, you need to have this molecular tumor board to have this strong and direct interaction between physicians, patients, and the molecular pathologist. And the last point, you need to have access to tumor tissue or to the blood. So this is clearly also an issue in some tumor types. So for example, for glioma, sometimes it's quite difficult to have access to tissue. Or for example, when you have only small biopsy, so it could be the case in bladder cancer, but also in other tumor type. Sometimes we need to discuss with patients to have a rebiopsy or to have blood tests that are in development. So I guess, to my point of view, this is clearly a very promising approach in all these tumor type. All the experience of a bladder cancer expert are very important because you work on the field 5 years before everybody. So we probably need to have more interaction with a bladder cancer expert, pathologists, and physicians, because they treated also a lot of patients with erdafitinib. And there are other FGFR inhibitors in development. And this kind of approach is probably interesting for rare cancer. So we talk about colon carcinoma, glioma. It's also true in children. So in some pediatric cancer, you have FGFR alterations, in particular in glioma or in sarcoma. And it could be also interesting to develop this FGFR inhibitor in very rare cancer like children cancer.
And that's for sure pretty. What you said is the size sample is one of the problems. The second problem is the tumor heterogeneity, not so much in gliomas, but very much in bladder cancer, but where we know after lung cancer and melanoma, it's really one of the most heterogeneous tumors. So our problem is, for example, which sample we shall take, because you can have one sample and it's really kind of wonderful mutation, fusion, whatever you want of FGFR3, and by bad luck, you take the other block and there's nothing in it. And it's just, you know, it's just like, yeah, you don't find anything. So that's a little bit problematic, especially in bladder and also in lung cancer, where sometimes I think there are some trials. And the second problem is, of course, if you have a very small sample, well, in bladder, very often you have huge tumors, so you can do rebiopsy. But of course, in gliomas, as you said, it's really problematic because we have to make a diagnosis first, and then we can only do the screening. So histology always is first, I'm sorry to say, so that you have at least a correct diagnosis. So that's really a very huge problem, yes.
Yes, for sure. And the last point is to have access to FGFR inhibitors. So you have clinical trial ongoing, but also in different countries, like in France, you have access to compassionate use. So I think in this molecular tumor board or in this the multidisciplinary tumor board, it's important also to discuss compassionate use access, because it's very frustrating for physicians, pathologists, and also patients to identify mutation, but not have access to drugs. So I think we need probably to educate ourselves, physicians, but also patients, to give this information that FGFR inhibitor is available with compassionate use outside proper clinical trial. So it's always good to enroll patient in clinical trial, but sometimes it's not possible or it's not feasible. And so you have this possibility to have the compassionate access.
I just wanted to ask you one thing, because there are trials which have shown that if you treat the patients before with a checkpoint inhibitor, and then you give an FGFR-3 inhibitor, these patients react better. We know that for the bladder. Is this also true for cholangiocarcinoma, and all these gliomas and all these kind of tumors where you treat them?
Yes, the question is how to choose the best treatment, right?
Mm-hmm.
Yeah, so for sure.
Because we know from the bladder that sometimes you have these immune excluded tumors in the bladder, and you give them before immune checkpoint inhibitor, and afterwards you give them FGFR3, sorry, and then you see they react pretty well. We don't know exactly the mechanism. Maybe there's a kind of activation of this T cell lymphocytes, but do you know something about this?
So this is a very good question. We don't have an answer. I think in this RAGNAR trial, this is very advanced cancer patients. So that means patient with refractory cancer. So there is no, I would say, better option than clinical trial or compassionate use. But at some point, and I think it's a good lesson from bladder cancer, how to choose the better drugs in this field. We don't know. And I guess at some point, we'll need to have some combination trial. And sometimes it's not so easy to do, or to have some sequential trial. And I think because you are advanced in the field, I think we will have some lesson from you in bladder cancer, and maybe to try to extrapolate to other tumor type. So another point important to consider in the FGFR development, FGFR inhibitor development, is the efficacy and the level of efficacy of this drug. So we have some demonstration of activity of this drug in different tumor type with different drug from different company. Most of these drugs have been focused on patients with FGFR positive tumor. Clearly, this drug do not have any activity in patients with non-FGFR activated tumor type. So it's very important because the development of this drug is clearly linking to the molecular screening. We also need to consider that most of the patients enrolled in clinical trial are enrolled in second, third line, or further line of treatment. That means patients with very advanced and refractory tumor types. So most of the time, we have an activity with 25 or 30% of response rates, which is quite high in patients with advanced tumor type. And we have a duration of treatment between 6 or 9 months. That means it's probably very close to what we see in lung cancer in second, third line with FGFR inhibitor. We don't have a lot of data concerning FGFR inhibitor in earlier line, because we probably believe that in early line, probably FGFR inhibitor will be more active. But we have also the discussion concerning the best treatment for patients. And because there are other options, in particular in bladder cancer, it's not so easy to have data on patients with naive bladder cancer or other tumor type and FGFR activation. So what we can say that we have different FGFR inhibitor in development. The activity seems promising, and what we see in these oncogene de-addictions, and we need to demonstrate first the activity in different tumor type with no standard of care, and then we will have a question of a combination of a sequence of treatment. And for me, it's clearly an option for patients, and this option is only available if we have access to molecular screening for patients.
Well, I think there's some trials just starting, so we don't have any data, but as these non-muscle invasive tumors, for example, in the bladder, overexpress very frequently FGFR3 and BCG, there's a kind of shortage. So it would be interesting, instead of giving maybe Pembro, but giving something like FGFR3 inhibitors in these kind of stages, so PTA and PT1 stages, but we still do not have any data, really reliable data on this, but this is something which is certainly upcoming.
Yeah, for sure. It will be very interesting to have this data. And once again, bladder cancer will probably show us the path, because you have more data. And so I think you will have more data for this earlier stage. And for us, it will be very important to have this data in bladder cancer. Thank you. So thank you, everybody. Thank you, Dr. Compérat. And I wish you a very good day. And thank you so much.